Okay, it is the first lecture on pharmacology of CNS, and on this topic we are going to talk about sedative and hypnotics. Okay, talking about sedative and hypnotics, the initial thing that we need to know is we need to know about the meaning of sedative and hypnotics. Okay, now what is the meaning of sedative? Sedative means, okay, these are the drugs that will induce what? Drowsiness. That will induce drowsiness. And what are hypnotics? Hypnotics are the drugs that are what? That will induce sleep. Okay, now drowsiness is the condition just before sleep. Okay, we can say that it is a condition that will happen just after 30 minutes of what? Lecture. After 30 minutes of lecture. And what is the sleep? Sleep is a condition that will happen after what? After 1 hours of lecture. So sedative and hypnotic, these are what? These are done by same drug, right? These are done by same drug. Only the difference is that the same drug, if it is given at low dose, right, if it is given in low dose, then it will act as sedative, and if it is given in higher dose, then it will be acting as hypnotic. That's all. Okay, now after this I would like to take you toward one channel, and this is what? This is our chloride channel, right? Chloride channel complex that is present in where? In our what? CNS. Okay, now here as you can see, this chloride channel, it is what? It is containing what? It is containing receptor, it is containing what? It is containing channel, and this channel is allowing what? Chloride to enter. Okay, now in brain there is channel, and that channel will help to that help for entry of chloride, right? Chloride ion inside it. Now over this channel there are receptor for various things, such as there is receptor for what? Gaba. Okay, there is receptor for Gaba A, right? Okay, Gaba A. Okay, and this receptor is along with this receptor there are also receptor for other substances such as barbiturate, also benzodiazepines. Okay, now whenever GABA comes, okay, whenever GABA comes, and it will what? It will come and it will just what? It will bind in this receptor. At that time what will happen? It will stimulate this receptor. It will stimulate this complex, chloride complex, and because of this stimulation what will happen? This chloride ion, it will get into what? CNS. Since chloride is negatively charged, what will happen? As it enters into the cell membrane, what will happen inside the cell? There will be what? There will be negative potential development, right? Negative potential development. Now these negative potential development, it will cause what? It will cause normal resting potential to go from -70 all the way to -80, -90, like this. And there will be the condition in which what? Our cell membrane will be hyperpolarized. Okay, we were talking that there is GABA will come, it will stimulate what? It will bind with GABA receptor present on this chloride complex, channel complex. This will cause what? This will cause influx of chloride into the cell membrane, and this, as the chloride is negatively charged, what will happen? Negative potential will be developed inside the cell membrane, and that will cause what? That will cause our what? Resting potential membrane to go what? Hyperpolarized state, right? Hyperpolarized state. As it will undergo hyperpolarized state, it means what? It means that what? This means that our cells now, they cannot be stimulated, right? They can't be stimulated. As they can't be stimulated, right? As they can't be stimulated, it means that our brain, it is what? It is depressed. Okay, as I've already mentioned, over this complex, which complex? Our this chloride channel complex, there is not just our this GABA receptor. There are also several receptor, like what? Benzodiazepines, right? Receptor for benzodiazepines, and also there are receptor for barbiturates. Now whenever benzodiazepine will come, right? Whenever benzodiazepine or barbiturate, they will come and they will bind in this side, what will happen at that time? This chloride complex channel will get stimulated, and it will cause influx of chloride, as we discussed earlier, and that will what, that will cause depression of brain. And what will happen, it means that these barbiturates and benzodiazepines pines, they will also what, they will also act as what, sedative and hypnotics. Okay, okay, we knew earlier what, we knew earlier that what is our GABA is inhibitory neurotransmitter of brain. What it is doing, it is what, it is depressing or it is inducing sedation or hypnotics in brain. Similarly, barbiturate and benzodiazepines, these are also what, these are also causing what, these are also causing sedation and hypnotics. Okay, we have got a brief idea about what, about sedative and hypnotics. Okay, let's move toward what, this receptor in detail, this receptor. Okay, now what is this, this we can say this complex as GABA. Okay, this, what is this complex, it is chloride, what is this is chloride channel complex, right? Okay, now here now this okay, now here what we have got, GABA receptor, right here, GABA receptor. Now let's talk about this GABA receptor. Okay, now here this GABA receptor, okay, this GABA receptor, this is, okay, let me write GABA, right, A receptor. This GABA A receptor, it is pentameric in form, pentameric. Why it is pentameric? Because it is made by what, it is made by 2 alpha, 1 beta and 2 GABA units. Okay, let me draw here for you. Now this is what, this is our lumen, right, lumen. Okay, it is formed by what, it is formed by our what, 5 subunits. This is 1, this is 2, this is 3, this is 4, and this one is our 5. Okay, now as I have already mentioned, how many alpha are there, 2 alpha are there, right, these are the alpha. Okay, how many gamma are there, 2 gamma are there, and how many beta, 1 beta is there. Okay, okay, now this is our what, this is GABA receptor. Okay, here if you will see, initially what will happen is that this lumen will be what, this lumen will be closed, right, this lumen will be closed. It is closed means chloride ion is not able to pass through this lumen, it is not able to pass through this lumen. Now what will happen is that, right, what will happen is that there is receptor. Now the name of that, there is receptor between what, there is receptor between our alpha and gamma subunits, right, and this receptor is what, this is our GABA receptor, GABA A receptor. Now as this GABA A receptor will come, as this GABA A receptor, as in this GABA A receptor our GABA will come and will bind here, then what will happen is that these, right, okay, these our what, these closed structure, they will what, they will come back, and now this chloride ion, now it can easily pass. Okay, this is the mechanism. What is going on, GABA is coming, this gamma is coming and binding with what, GABA receptor, GABA A receptor, and because of binding to GABA A receptor, what will happen, this will be stimulated and there will be passage of what, chloride ion. Similarly, what about our barbiturates and benzodiazepines? Okay, now these benzodiazepine, what they will do is, the receptor for benzodiazepine, it is present where, it is present somewhere around this alpha and gamma subunit. Okay, this is the receptor for what, it is the receptor for benzodiazepine, right. Now what will receptor for benzodiazepine, and what will bind here in this receptor of benzodiazepine, there will be binding of how many, 3 things. One is our agonist, right, another is our inverse agonist, and another is our antagonist. Okay, talking about agonist, what is agonist? Okay, the agonist, benzodiazepine itself, it will go and it will bind right here. And talking about inverse agonist, what will bind here, inverse agonist will go bind here and it will cause what, it will cause opposite effect. Now what is this inverse agonist? It is carbolin. What is it? It is carbolin, right. Similarly, the most important, the antagonist. Now what is this antagonist? The antagonist, what it will, what, it is competitive antagonist, right, it will go and bind where, in this side, benzodiazepine site, right? On where? On this GABA receptor. Okay, now this, what is this antagonist? It is our flumazenil, flumazenil, right? Okay, flumazenil. Why it is so important? It is important because it is drug of choice for what? Benzodiazepine, what? Benzodiazepine toxicity. Okay, and how we are going to provide it? We are going to provide it IV route, through IV route, right? And its duration of action is about how many? 45 minutes. Okay, we are talking about what? We are talking about this benzodiazepine receptor, right? What can bind there? Okay, here in this benzodiazepine receptor, here benzodiazepine will come, benzodiazepine will come, and it will what? It will this benzodiazepine will stimulate, our this chloride channel, right? Opening of chloride channel, or we can say it will stimulate chloride channel with the help of this GABA, right? GABA receptor, and that because of which our this chloride will easily what? It will get what? It will start influxing into the cell. Okay, now one important point that I would like to mention right now is that benzodiazepine, what it will do is it will increase what? It will increase it will increase influx of chloride into the cell, right? How it will increase? It will increase by what? By increasing the number of what? By increasing number of times of opening of our chloride channel. That means it will increase what? It will increase number of opening of chloride channel, right? Number of opening up chloride. Before benzodiazepine, suppose before benzodiazepine the chloride channel was open how many? 5 times. Okay, let's suppose that it was opening how many? 5 times. 1 2 3 4 5 times, and 2 millisecond each, right? That means total duration how much? It will open it for how much? It will open for 10 milliseconds. Now after benzodiazepines, what will happen is that it will increase the duration. That means it will increase duration. Now how many time it will increase? It will increase how many? It will increase the number of time of opening. That means it will increase what? It will increase the frequency. That means now 10 times the chloride channel will be opened. Now let's suppose 2 millisecond each. Now how many times the chloride channel? Now for how many times this our chloride channel will be open? It will be open for 20 millisecond. So now if it is increased 20 millisecond, then obviously before it was 10, now it is 20. So what is going on? The more chloride ion is getting inside the cell, that means more more hyperpolarization is taking place, and the brain is what? Depressed, more sedative and hypnotic action. So this was how benzodiazepine works, right? Mechanism of action of benzodiazepine. Okay, now talking about what? Okay, now let's talk about barbiturates, right? Now barbiturates, what they will do is, now barbiturates also, it also helps in what? It also help in opening of help in opening of chloride channel. Now how it will do is, now as we have said that our benzodiazepine receptor was present right here between alpha and gamma subunit. Our our barbiturates, where it is present? Barbiturates are present right here, where? In alpha and beta subunit, between alpha and beta subunit. Okay, alpha and beta subunit. Now these alpha and beta now here how barbiturates will work is that the barbiturates, it will not, as we have mentioned that what our benzodiazepines, it was increasing the number of time of opening of chloride ion, such as it was increasing the frequency of opening of chloride channel. Now but these barbiturates, right, these barbiturates, what they will do is here, these barbiturates which are binding right here, what they will do is they will open this chloride channel for more duration, right? For more duration, they will open it for more duration. But here our benzodiazepine, they were they were increasing it for more number of times, but here duration is more, such as before giving barbiturates it was opening how many times? 5 times, 1 2 3 4 5 times, right? But now what will happen is that it will open for how many? Just for example, it was opening for 2 millisecond, right? Duration was 2 millisecond. Now what will happen is that these 2 milliseconds, now it will increase. Okay, the frequency is same, the number of time is same, right? But it will open for 4 milliseconds. 4. That means 5 times 4 is our 20 millisecond. It will open for 20 milliseconds. Okay, it works like this. Yes, we talked a little bit detail about brief about barbiturates and benzodiazepines, right? Benzodiazepines and barbiturates. Now let's move a bit more detail about these things. Okay, now talking about benzodiazepines and barbiturates. Okay, the first difference between barbiturates and benzodiazepines is that barbiturates, it mimics the action of GABA, right? It mimics the action of GABA. That means what it will do is, right, like GABA, they will open the chloride channel, right? They will open chloride channel. They will open chloride channel. But benzodiazepines, they facilitate GABA. That means they will themselves not open chloride channel, but they will they will help GABA. Right? They will sit in one chair and they will say GABA to just open chloride channel. That means they will give order, right? They will give order. They are benzodiazepines, they are indirectly doing it, but barbiturates, they are directly, right? Like GABA, they are opening the chloride channel. And talking about duration, right? Okay. Now these barbiturates, right? Talking about the chloride channel, how they will act on chloride channel. Barbiturates, what they will do is they will increase the duration. As I've already said, they will increase the duration. But the benzodiazepines, they will increase the frequency. As I have already mentioned, if in normal individual, let's say that, okay, normal individual, if the normal individual is under GABA, then what will happen? 2 millisecond, chloride channel will open for how many? 2 millisecond, 1 2 3 4 5, 2 millisecond. That means what will happen here? Chloride channel will open for how many? 10 milliseconds, right? 10 milliseconds. But if we give barbiturates, right? Barbiturates, what will happen is that the duration will increase. That means it will open for how many? 1 2 3 4 5 times. But now it is the duration is increased, right? 1 2 3 4 5. That means it will open for how many? 4 milliseconds. Total is our 20 milliseconds. Before how many? There was 10 milliseconds, but after 20 milliseconds. That means it will increase double, right? The sedative and hypnotic action will be double. Similarly, talking about benzodiazepines, right? What it will do is it will increase frequency. That means before 5 times it was opening, but now how many times? 10 times. 1 4 5 6 7 8 9 10. That means 1 is 2 milliseconds. Now 2 times 10 is our how many? 20 milliseconds. Okay, so this is what we say the difference between barbiturates and benzodiazepines. Now moving further, talking about DRC. What is this DRC? It is dose response curve, right? Talking about DRC, what we will find is in barbiturates there is steep DRC, right? Now steep DRC, as you remember, we studied these things in our basic, right? General pharmacology. Steep, that means, okay, this is our steep DRC. And in benzodiazepines we have we have flat DRC. This is our flat DRC. Now this steep and flat DRC, what does it means, right? DRC, right? DRC, dose response curve. Slope, here we are talking about slope. And slope, what does slope denote? Slope denotes from S for slope and S for safety, right? Now here in barbiturate we have got steep, right? We have got steep slope. That means, right? That means with slight increase in with slight increase in dose, the response will be increased in high amount. So with slight increase in slope, or let's say with slight increase in slope, there will be rapid response increase, and these drugs are unsafe, right? But here in benzodiazepines we can see that the response will increase progressively with slope or with dose. So So the barbiturates are what? These are not safe drug, right, compared to benzodiazepines. And talking about inducers, right, talking about inducers, I would like to mention that these barbiturates, these are what? These are strong inducers. These are strong inducer. What they will do is they induce normal physiological enzyme also, right? These barbiturates, they induce normal physiological enzyme also, like what? I would like to mention one enzyme, that is like what we have got. We have what? Delta amino, okay, delta amino levulinic acid synthetase, right? They induce this enzyme. Now if this enzyme will be induced, if you recall hematology, right, if this enzyme will be induced, what will happen? There will be what? Excessive formation of porphyrins, because these delta what? Amino levulinic acid, it is what? It is this alpha amino levulinic acid, it is rate limiting enzyme in formation of porphyrins, right? Porphyrins. So now when an individual is given barbiturates, right, this will cause what? This will cause stimulation of these what? Amino levulinic acid synthase. Now if there will be excessive stimulation of this rate limiting enzyme, then what will happen? A lot of porphyrins will be what? Formed, and these a lot of porphyrins, it will give rise to what? Acute intermittent what? Porphyria. It will give rise to acute intermittent porphyria. So barbiturates is contraindicated in patient with acute intermittent porphyrias, right? But we can use what? We can use benzodiazepines. So this was about what? Inducer. But here benzodiazepines, they are not what? They are not inducer, right? And talking about addiction, our barbiturates, they are so very much addictive. Benzodiazepines are also addictive, but they are comparatively less addictive. And talking about amnesia, what is amnesia? Amnesia means what? Loss of memory. And barbiturates, you will see that there is what? There is excessive chance of amnesia, but in benzodiazepines there is less chance of amnesia. Similarly, talking about antidote, barbiturates do not have any antidotes. They do not have any antidote, but benzodiazepines, they have antidote, that is flumazenil. What is the antidote for benzodiazepines? That is flumazenil. If you will see the what? See these benzodiazepines, at last we will find what? PINE, right? What is this PINE? Pine, right? Pine. Pine means what? Pine. Roxypine, right? Roxypine. Now this pine, roxypine is what? It is what? It is maza, right? Maza activity, right? It is after roxy, with drinking roxy, will have there will be maza, and this flumazenil, it will what? It will nil the effect of this pine. We can memorize that roxy पिउने मान्छेको जुन मजा छ त्यो मजा फ्लुमाजेनिलले के गर्दिन्छ? कम गर्दिन्छ. Like this we can memorize it. Okay, yes, this was what? This was about difference between barbiturates and benzodiazepines, or we can say that if you'll see what? If you'll see these last note, these what? These points, right? If you see these point, you'll see that according to DRC, barbiturates, these are not safe drug. Inducer, they are enzyme inducers. They are prohibited in patients suffering from acute intermittent porphyria. They are so addictive, they are also responsible for loss of memory, and they do not have antidote. Now because of all these things, right, because of all these things, what you will conclude? You will conclude that benzodiazepines, right, benzodiazepines, they are what? They are comparatively what? They are comparatively what? They are efficient than these barbiturates. That is one outcome, right? So benzodiazepines are excessively used than barbiturates. This is one reason. Okay, now what? Now let's talk about some of the drug, right? Some of the barbiturates, right? Talking about barbiturates. Now, talking about barbiturates, okay, let's talk about what? Barbiturates. Now talking about barbiturates, we already talked about its mechanism of action, how it will act, right? Now let's talk about its classification. One is our long acting one, another is our short acting, another is our what, ultra short acting. Now talking about long acting, these are phenobarbitones, and these are excessively used for epilepsy, right? What are these? These are phenobarbitones. Now talking about phenobarbitones, right, these are what, these are used for what, these are used for epilepsy, right? Now here I would like to add one thing. Okay, now before, as we have studied about what, as we have studied about this alpha receptor, now I would like to take you toward this alpha receptor. This alpha receptor is further divided into two parts. Now what are the two parts of alpha receptor? One is alpha 1 and another is alpha 2, right? One is alpha 1 and another is what, our alpha 2. Now talking about this alpha 1 and alpha 2, this alpha 1, right, alpha 1, these are responsible for what? These alpha 1 are responsible for sedation and hypnotics. These are responsible for sedation and hypnotics. And talking about this alpha 2, these are responsible for what? These are responsible for anti-epileptic action, right, and also for muscular relaxant. Now here, right, now since this alpha 1 is only responsible for sedation and hypnotics, so we can use what, we can use nowadays the jet drug or newer non benzodiazepine hypnotics, right, zopiclone or zopiclone, zolpidem, these are used nowadays, that are called jet drugs, right? Jet drugs are used excessively nowadays for what, for sedation and hypnotics. And as I've already said that anti-epileptic, right, and this our muscular relaxant, these are present on what, alpha 2. So for anti-epilepsy we'll use what, drug that will excessively act on alpha 2 region. Now as I've already mentioned that barbiturates are present right here, so what, they have action in this alpha 1 and alpha 2 both, and for in alpha 2, when they will act in this alpha 2, they will what, they will provide anti-epileptic action also. So what I'm saying is that phenobarbitone, right, phenobarbitone, as I'm mentioning right now, these are what, these are drugs that are used for anti-epileptic. Short acting, in short acting, what we have got, we have got butobarbitone, what, butobarbitone, and we have got what, pentobarbitone. Similarly, ultra short acting, what we have got, thiopentone. Now this thiopentone is important, thiopentone, okay, pentone. Now thiopentone, what is this thiopentone? This thiopentone is used for what, this it is used for sedation, right, it is used for sedation, anesthesia, right, short anesthesia. Okay, so these are the commonly used barbiturates nowadays. And talking about what, now let's talk about what okay, now let's talk about benzodiazepines. Now talking about benzodiazepines, it includes drugs such as diazepam, flurazepam, nitrazepam, fluornitrazepam. Now as you can see, there is one term, oxazepam. Now what is this oxazepam? It is a metabolite form of our benzodiazepines, right? It is a metabolite form of benzodiazepine. Now it is important to study this oxazepam, because this is the reason why benzodiazepam are longer acting drug. These are longer acting drug. Okay, now how these are longer acting drug? Okay, let's say we gave what, we gave diazepam. What we gave diazepam. Now this half-life of this diazepam, it is, let's say, 6 hours. Now after this 6 hour, what it will happen is that these diazepam, now they will convert into what, oxazepam. Now as they will be converted into oxazepam, now the half-life of this oxazepam is further again 6 hours. That means the person will be sleeping for how many, 12 hours. So what, these benzodiazepines are what, these are the long acting drug, and this is because of what, because of these active metabolites. Okay, now since the person is having a long half-life, right, these are the longest acting one. If after 7 hours, let's suppose the person is having diazepam, right, and after 7 hours if the person wakes up, now after 7 hours if the person wakes up, then obviously there will be what, there will be effect of what, our oxazepam. Now because of this effect, the person will be what, suffering from what, hangover, right, hangover. And another important thing about this thing, about right here, is the these drugs are contraindicated in elderly people. Why it is contraindicated? Because elderly people are more sensitive to CNS depression. And the fun fact is that elderly people are only the one who are having what? Sleep disturbance. They are the one who will require this, but these are contraindicated in elderly people. Why? Because elderly people are more sensitive to CNS depression. And these are also contraindicated in liver failure. Why these are contraindicated in liver failure? Because what? Why? Because if there is failure of liver, they won't get metabolized, and if they won't get metabolized, they will get accumulated over the period of time, and what will happen? There will be the production of toxic substances. Okay, now there are some of the example of benzodiazepines, right, which do not have active metabolites. They are not having active metabolites, and if they are not having active metabolites, then obviously they will not cause hangover, they will be not contraindicated in elderly people, right? They will be not contraindicated in liver failure. Okay, now what are the drugs? The drugs can be memorized as STOLE, stool, right, from as short acting benzodiazepines. Why short acting? Because there is no active metabolites. That means here this oxazepam, there is no role of oxazepam, only diazepine, which is 6 hours, right, which will act for 6 hours, will come into the action. So here these are short acting benzodiazepines, right? Temazepam, oxazepam, lorazepam, and estazolam. Okay, now these are the drugs that are not having what? That are not having active metabolites. Okay, now I would like to add another point right here. Let's talk about something about sleep. Talking about sleep, right? Sleep, right? There are how many? 2 phases of sleep. One is REM, rapid eye movement sleep, and another is our non-REM. Now out of these 2 sleep, in which we will get dream? In both the condition we'll get dream, right? We'll dream in both the condition, but the dream that we saw will be remembered only in this REM phase. So as you can just memorize it in such a way, remembering of dream, REM, same thing, right? Remembering of dream will happen in this REM phase, rapid eye movement phase, but it will not happen in non-REM phase. Okay, now we talked about 2 phases, REM and non-REM. This non-REM, it consists of again further phases, the phase 1, 2, 3, 4, right? Now for quality sleep or for complete sleep, right, for quality sleep, all these REM and the different phases of our this non-REM, these are need to be what? These are need to be completed, right? These are need to be completed for quality sleep. Okay, now why we are talking about this sleep? Why we are talking about sleep? Because we need to know about good quality sleep, right? Good quality sleep is the sleep in which sleep architecture, such as all these phases, right? These phases of REM and non-REM, REM is maintained, right? They are maintained. But what will happen if we give what? Benzodiazepines and barbiturates. Now when we are giving these, right, these hypnotics, at the time this normal architecture of our sleep, that means this normal sleep architecture, it will be disturbed, it will be distorted. Okay, what I'm saying, good quality sleep is the sleep in which sleep architecture, phases of REM and non-REM are maintained. They are maintained. But barbiturates and benzodiazepines, when they are given, this barbiturates and benzodiazepines, when they are given, what will happen is that it will distort the normal sleep architecture. That means quality of sleep will be disturbed. Now how the quality of sleep will be disturbed? Because as we have mentioned, what? As we have mentioned that REM sleep, non-REM sleep, right? 1, 2, 3, 4 phases of non-REM sleep. Now for quality of sleep, but what should happen is that these all the phases, right? These all the phases should get their adequate duration. But when we give benzodiazepine and what? This barbiturate, what will happen is that these phases will not get time. That means the time these benzodiazepine and barbiturates, they will increase the duration. They will increase the duration of sleep. As we have already seen, the 10 millisecond, as the chloride channel that was open for 10 millisecond, these were increased to 20 millisecond because of these benzodiazepines and barbiturates. It is increasing the duration of sleep, but the quality of sleep is distorted. Why? Because the time that it is increasing is not proportionately distributed among these phases. So okay, now let's talk about what. So there is what disturbance in normal sleep architecture. Quality of the sleep will be what reduced because of induction of these barbiturates and benzodiazepines, and it will also what decrease the latency of sleep onset. What is the latency of sleep onset? So we are mentally prepared at 11 p.m. to go into sleep, right? But we will get into sleep at 11:30. Now this duration is our latency period. Now what these benzodiazepines and barbiturate will do is they will decrease the sleep latency, right? It will bring somewhere like here. Okay, let's say in the case of insomnia, what will happen? Normally what happens in the case of insomnia? The person will go to sleep being mentally prepared at 11 p.m. but the person will get into sleep at 4 a.m. So there is large latency, right? Now these benzodiazepine and barbiturate, what they will do is they will decrease the latency, sleep latency. So what these benzodiazepine and barbiturate they do, they decrease the latency of sleep, right? They increase the quantity of sleep. That means the duration is increased. We discussed about these things earlier. Okay, that means through the use of barbiturates and benzodiazepines, right, we are not able to get quality sleep. We are able to get quantity. I mean, we are able to get enough sleep for 8 hours, 9 hours, but we are not able to get quality sleep. Now how? Now we need some drug, right? We need some drug that will help to maintain the quality sleep. That means that will decrease the latency, right? That will decrease the latency, and that will not hamper the quality of sleep. And these drugs are our jet drugs. These are jet drugs, and these are also called newer non-benzodiazepine hypnotics. Now why they are called jet drugs? Because every drug, right, maximum every drug, their name start with jet, except this SGOP clone, right? SGOP clone, what it is this, okay, okay, except this, it is recently discovered drug. Okay, now what these jet drug will do is they will decrease the latency, right? They will decrease the latency, and there is no effect in quality of sleep. That's why. So these jet drug, what they will do is they will stimulate alpha 1 subunit, right? If you remember, alpha 1 subunit, it was responsible for sedation and hypnotic, right? We discussed this thing right here. This alpha 1, it is responsible for sedation and hypnotic, and I have mentioned earlier that these are jet drug that will act here. So these jet drug, what they will do, they will stimulate alpha 1 subunit, or sometimes it is also called omega 1 subunit of benzodiazepine receptor. It will decrease the latency. It does not decrease the duration of sleep, right? Duration of sleep is not decreased. Now because of use of these jet drugs, it lacks anti-anxiety. It will lack anti-anxiety, it will lack muscle relaxant, anti-convulsive property. That means, as I have already mentioned, that overall benzodiazepine, right, they were acting overall in this alpha unit, right? And this alpha unit, it was divided into alpha 1 and alpha 2. This alpha 1 was responsible for what? It was responsible for sedation and hypnotic, right? And this alpha 2, it was responsible for what? Anti-epileptic, muscle relaxant property. So since this jet drug is only acting on this alpha 1 receptor, obviously it will be it will be involved in our hypnotic and sedative property only, right? Sedative and hypnotic only. So these alpha 2, right, alpha 2 action are not performed. That means there will not be what, there will be not anti-anxiety, there will be not relaxation of muscle, there will not be anti-convulsive or anti-epileptic property. So that's simple. It will only show what, anti-hypnotic property. Now the antidote for our these jet drugs is also flumazenil, right, flumazenil, which was for benzodiazepines. Okay, and these jet drug, these are the drug for drug of choice for insomnia, and these are drugs that are excessively used nowadays. Now I would like to take you toward another thing. Another thing is, let's talk about melatonin receptor agonist. Now why we are talking about melatonin receptor agonist? Because melatonin is responsible for our day night cycle. Now these melatonin, these are secreted at night, and they produce what, sedative effect. So if they produce sedative effect, then it is obvious to discuss about this drug right now. Now yes, they maintain day night cycle, and there is one important what, melatonin receptor agonist, that is Rameltion. Now Rameltion, as name suggests, RA and meltion, you can memorize it in such a way. That's meltion, what is it is melatonin, and RA is receptor agonist, So Rameltion is receptor agonist for our melatonin, right? Okay, melatonin receptor agonist. It is indicated for jet lag. Now what is this jet lag? Suppose the person is suffering traveling from one country to another country, at that time what will happen? Such as, for example, the person is traveling from Nepal to what, Nepal to US. At that time what will happen? The day night cycle, they will get opposite. So to bring in balance, right, to bring in balance, melatonin need to be what, produced at night of that country. So what we do is, at night of that country we provide Rameltion, right, Rameltion, so it will solve jet lagging problem. Similarly, shift worker and also in insomnia. One demerit of this melatonin is that it has less than 2% of oral bioavailability, so it need to be injected time and again. Now in overdose of this Rameltion, there is seen psychiatric adverse effects. It is metabolized by microsomal enzyme, right, so there can be a lot of what, drug interactions. Okay, this was about what, this was about our melatonin receptor agonist. Talking about what now, another orexin receptor antagonist. Now here we are talking about antagonist. That means orexin is responsible for what, it is responsible for wakefulness. Now when this factor which is stimulating wakefulness is what, antagonized, what will happen? Obviously sleep, right, hypnotic. So the orexin receptor antagonist, that is suvorexant, right, suvorexant. Now from the name it suggests SUV, right, suvorexant, right, SUV, it helps in what, sedation. From S we can get it, sedation, right, it's the use of this suvorexant. And from this OREX, right, orex, this is what, orexin, right, orexin and antagonist, Okay, so this was about what, this was about various drugs that are useful in what, hypnotic and sedation. I hope it's clear. So this much for this lecture. Hope you have a great time.